I want to tell you about a patient of mine. Her name is Margaret. Margaret is 69 years old, and she came to see me 14 months ago. Not because she was unwell, not because she had any symptoms that concerned her. She came because her daughter had read an article about chronic kidney disease and had quietly worried that her mother, who had high blood pressure and type 2 diabetes and who was on several medications, might be worth checking more carefully than she had been. Margaret sat down in my office and she told me she felt fine. She was a little tired, but she was 69 and everyone was a little tired. She had some ankle swelling at the end of the day, but her previous doctor had said it was the amlodipine and not to worry about it. She got up once, sometimes twice in the night to urinate, but that was normal at her age, wasn't it? She was not in pain.
She was not short of breath. She was not experiencing anything that she would have described to anyone as a symptom. And yet, when I looked at her medical records that she had brought with her, 14 months of blood test results from her previous practice, I found something that stopped me and made me sit very still for a moment before I spoke. I found a number that had been on every single one of those blood tests for 3 years, a number that had been moving in one direction slowly but consistently and without interruption for 3 years, and that had never once been specifically mentioned to Margaret by her doctor. That number was her eGFR, her estimated glomerular filtration rate, the most accurate measure of how well her kidneys are filtering her blood. 3 years ago, her eGFR was 64. 2 years ago, it was 59. 18 months ago, it was 54. A year ago, it was 51. And at her most recent blood test, 6 weeks before she came to see me, it was 47. From 64 to 47 in 3 years, a decline of 17 points of kidney filtering capacity. That had happened right there on the printed blood test results. That had been filed in her medical notes without anyone sitting down with Margaret and saying, "Margaret, your kidneys are losing function, and we need to talk about why and what we are going to do to slow it down." I looked at Margaret and I said, "Margaret, I need to talk to you about something." That should have been talked about a long time ago. And what I told her that morning is what I want to share with you today. Because Margaret is not unusual. In fact, she represents something that I see with a frequency that I find genuinely troubling in my clinical practice. Chronic kidney disease that is progressing in plain sight on every blood test that a patient has had for years without anyone connecting the dots, naming the trend, and having the conversation that could slow or stop what is happening before it becomes something much more serious. I am Dr. Daniel Chen, and today I want to explain what eGFR actually is, why it is on almost every blood test that adults over 60 have, what the numbers mean, what chronic kidney disease is, and what every adult over 65 with high blood pressure or diabetes, or anyone taking the medications I have discussed in previous videos needs to know about the kidney function number that is already on their blood test right now and may have been telling a story for years that nobody has explained. So let me start with what the kidneys actually do, because most people know the kidneys filter blood, but the kidneys do far more than that. And understanding what the kidneys actually do for the body is what makes the stakes of their decline feel as real as they actually are. Your kidneys are 2 fist-sized organs sitting in the back of the abdomen on either side of the spine. Together they filter approximately 200 liters of blood every single day, every 24 hours, without rest, without breaks.
And in the course of that filtering, they do 6 specific things that the body cannot do without. The first is waste removal. The kidneys filter out metabolic waste products, including creatinine, a waste product of muscle metabolism, urea, a waste product of protein metabolism, uric acid, the compound associated with gout, and many other metabolites that accumulate in the blood as the normal byproduct of cellular metabolism. When kidney function declines, these waste products accumulate in the bloodstream, reaching levels that are directly toxic to many body systems. The second function is fluid balance regulation. The kidneys determine precisely how much water is retained in the body and how much is excreted as urine.
When kidney function is impaired,
this regulation fails. Fluid accumulates in the tissues, causing the ankle swelling that Margaret had been told was just from her amlodipine, and in severe kidney disease in the lungs, causing breathlessness. That is one of the most serious complications of advanced kidney failure. The third function is electrolyte regulation. The kidneys maintain precise blood levels of potassium, sodium, calcium, phosphate, and bicarbonate. As kidney function declines, these balances are disturbed. Potassium rises, as I described in my video on kidney protective medications, threatening heart rhythm. Phosphate rises, drawing calcium from the bones and depositing it in blood vessels, contributing to arterial calcification. And bicarbonate falls, causing a chronic low-grade acidosis that damages multiple organ systems over time. The fourth function is blood pressure regulation. The kidneys produce a hormone system
called the renin-angiotensin-aldosterone system.
that is one of the primary regulators of blood pressure in the body. When kidney function is impaired, this system becomes dysregulated, raising blood pressure, which in turn causes further kidney damage, creating a vicious cycle that accelerates the decline of both the kidneys and the cardiovascular system simultaneously. The fifth function is erythropoietin production. Erythropoietin is a hormone produced by the kidneys that stimulates the bone marrow to produce red blood cells. When kidney function declines, erythropoietin production falls. Fewer red blood cells are produced, anemia develops, and with anemia comes the fatigue, the breathlessness, and the reduced exercise tolerance that Margaret had been attributing simply to getting older. The sixth function is vitamin D activation. The kidneys perform the final and essential step in activating vitamin D from its inactive form
into its active hormonal form, calcitriol, that regulates calcium absorption from the gut and calcium deposition into bone. When kidney function declines, vitamin D activation fails, calcium absorption falls, and bone health deteriorates at a rate that significantly exceeds the normal bone loss of aging. 6 functions, all impaired to varying degrees as kidney function declines. And yet, Margaret had been experiencing the early consequences of that impairment for 3 years without knowing that her kidneys were the reason. Now, let me explain what eGFR actually means and how to read the number on a blood test. Because once you understand what you are looking at, you will never look at a blood test result the same way again. Glomerular filtration rate is the measure of how much blood the kidneys filter per minute in milliliters per minute. In a young, healthy adult, the GFR is approximately 100 to 120 milliliters per minute. Because an accurate direct measurement of GFR requires a formal kidney clearance study, which is not practical for routine clinical use. A calculated estimate called eGFR, estimated glomerular filtration rate,
is used instead, derived from a simple blood test that measures creatinine, the waste product I mentioned earlier, and applies a formula that accounts for age, sex, and sometimes race to estimate what the actual GFR is likely to be. The eGFR result, expressed in milliliters per minute per 1.73 meters squared of body surface area, is then categorized into stages of kidney function. An eGFR of 90 or above is considered normal or increased function and is labeled kidney disease stage G1. If there are other markers of kidney damage, such as protein in the urine, an eGFR of 60 to 89 is mildly reduced, stage G2. An eGFR of 45 to 59 is mildly to moderately reduced, stage G3A. An eGFR of 30 to 44 is moderately to severely reduced, stage G3B. An eGFR of 15 to 29 is severely reduced, stage G4. And an eGFR below 15 is kidney failure, stage G5, requiring dialysis or transplantation. Margaret's eGFR of 47 places her in stage G3A, mildly to moderately reduced kidney function, which means she has lost more than half of the kidney filtering capacity she had at her functional peak, without a single symptom that she would have identified as kidney-related. Because chronic kidney disease in its early and middle stages is almost entirely silent. The kidneys have enormous functional reserve. They compensate for the loss of filtering units by increasing the workload on the remaining ones. And by doing so, they maintain apparently normal metabolic function in the blood. Until somewhere around stage G3B or even G4, when that compensatory capacity is exhausted and waste products begin to accumulate in the blood to levels that produce symptoms. This is why the only way to detect chronic kidney disease in its earlier stages, when intervention can make the most difference, is through regular blood testing of eGFR and of urine testing for protein, which is one of the earliest and most sensitive markers of kidney damage. And why the failure to track and discuss an eGFR trend that is moving in one direction over 3 years is not a minor oversight. It is a missed opportunity to intervene at the time when intervention matters most. Now let me tell you why Margaret's kidneys were declining. Because understanding the cause is what makes the management possible. Margaret had two conditions that between them account for the majority of chronic kidney disease in adults over 65 in the United States. The first was hypertension, high blood pressure, as I have explained in detail in previous videos. Sustained elevated blood pressure damages the glomeruli, the microscopic filtering units inside the kidney, scarring them, reducing their number, and progressively reducing the total filtering capacity of the kidney over years and decades. Margaret's blood pressure had been elevated for approximately 9 years before it was diagnosed. Because high blood pressure has no symptoms and had not been perfectly controlled for the first 2 years after diagnosis. Before the right medication combination was found, 11 years of elevated pressure on kidneys that were already beginning their age-related decline had contributed meaningfully to where her eGFR was when I first saw her. The second condition was type 2 diabetes, diabetic nephropathy. Kidney disease caused by diabetes is the leading cause of end-stage kidney disease, requiring dialysis in the United States. The mechanism is the damage that chronically elevated blood sugar causes to the small blood vessels.
inside the glomeruli of the kidney, thickening and scarring them,
reducing their filtration efficiency, and over years, producing the progressive decline in eGFR that characterizes diabetic nephropathy. Margaret had had type 2 diabetes for 7 years, managed with metformin, which, as I discussed in my video on metformin, requires careful kidney monitoring, particularly as eGFR declines below certain thresholds. And her blood sugar control over those 7 years had not always been optimal. Her HbA1c at the time she came to see me was 7.8%, above the target of below 7% for most adults with type 2 diabetes. High blood pressure, inadequately controlled for years. Diabetes with suboptimal blood sugar control, acting on kidneys that were already on a natural, age-related downward trajectory, had produced a decline that was visible on every blood test she had had. For 3 years, in plain numbers,
that nobody had connected into a trend and a conversation. Now, let me tell you what I told Margaret that morning and what we did together over the following months, because this is the part that I most want every person watching this video to hear. Chronic kidney disease in stage G3A with an eGFR of 47 is not a death sentence. It is not the end of the kidney's story. It is a point at which intervention can meaningfully slow and in some cases partially stabilize the progression of the disease. The research on what slows chronic kidney disease progression is clear and actionable and involves several specific and evidence-based strategies. The first and most impactful is aggressive blood pressure control to a target of below 130/80 and ideally below 120/80 in adults with chronic kidney disease. Research has consistently shown that aggressive blood pressure control slows the rate of eGFR decline more than any other single intervention. And for Margaret, whose blood pressure had not been aggressively enough targeted for her stage of kidney disease, intensifying her blood pressure management was the single most important step we took. I adjusted her medications to optimize both her blood pressure control and her kidney protection, choosing medications from the ACE inhibitor class, which, as I have discussed, have been specifically shown to slow kidney disease progression in patients with diabetes and proteinuria. Beyond their blood pressure lowering effect, the second strategy was optimizing her blood sugar control. Her HbA1c of 7.8% needed to come down to reduce the glycemic damage to the remaining filtering units of her kidneys. We reviewed her diabetes management and made adjustments that I discussed in detail with her and her endocrinologist, including the addition of a medication class called SGLT2 inhibitors, including medications like empagliflozin and dapagliflozin that have been shown in large randomized controlled trials, including the Credence trial and the DAPA-CKD trial, to significantly slow the progression of chronic kidney disease in patients with type 2 diabetes, and in some cases, in patients without diabetes, through mechanisms that are partly independent of their blood sugar lowering effect. These medications have become one of the most exciting developments in the management of chronic kidney disease in the past decade. And their introduction for appropriate patients has changed the trajectory of kidney disease progression in ways that were not possible before these drugs were available. The third strategy was dietary modification, specifically reducing dietary sodium to below 1,500 milligrams per day, which reduces the fluid retention and blood pressure elevation that excess sodium causes in kidneys that are already struggling to manage sodium balance, and reviewing her dietary protein intake, because while adequate protein is essential for muscle maintenance, in older adults, excessive protein intake
increases the metabolic load on the kidneys and may accelerate the decline of EGFR in patients with significant chronic kidney disease. I referred Margaret to a renal dietitian who worked with her to optimize her dietary approach for both kidney protection and nutritional adequacy. The fourth strategy was adding urine monitoring to her regular blood testing. A urine albumin to creatinine ratio, UACR, is one of the most sensitive early markers of kidney damage, measuring the amount of a protein called albumin that is leaking through the damage filtering units into the urine. Even small amounts of albuminuria that would not cause any noticeable symptom are an important marker of ongoing kidney injury and of cardiovascular risk that is independent of the EGFR level. Margaret's UACR, when we tested it, was 85 milligrams per gram, which indicates moderately increased albuminuria, and confirmed that her kidneys were under active injury beyond simply the reduced EGFR. Monitoring this number alongside EGFR gives a far more complete picture of kidney health trajectory than EGFR alone. And for Margaret, it confirmed both the need for and the urgency of the interventions we were making. The fifth strategy was reviewing every medication she was taking for its appropriateness at her current EGFR, as I discussed in my video on medications and kidney damage. Metformin requires dose adjustment when EGFR falls below 45. Margaret's EGFR of 47 was just above that threshold. But given the downward trend and the trajectory we discussed with her endocrinologist, whether to reduce the metformin dose preemptively before the EGFR fell further. And we reviewed every other medication she was taking for appropriate dosing and for any kidney toxic potential that needed to be addressed. Margaret came back at 3 months and she brought her daughter, the same daughter whose quiet worry about her mother had prompted the appointment, that found the trend that 3 years of blood tests had been recording without anyone reading the story they were telling. Her EGFR at 3 months was 49, up from 47, a small improvement, but in the context of a number that had been declining consistently for 3 years. A stabilization and a slight improvement was not a small thing. It was a direction change. Her blood pressure was 118 over 74. Her HbA1c had come down to 7.1%, and her UACR had reduced from 85 to 62. Margaret looked at me and said, "Dr. Chen, why didn't anyone tell me 3 years ago?" And her daughter, sitting beside her,
said the same thing with her eyes before she said it with her voice. And I want to say what I say to every family when I sit with them after finding something that should have been found sooner. I say, the most important moment is not when the trend started. It is not when the first test first showed the number moving in the wrong direction. The most important moment is this one, right now, when you know and when you can do something about it. Margaret knew, and she was doing something about it. And that was the beginning of a different story than the one that had been quietly writing itself in her blood test results for 3 years without anyone reading it to her. Now let me tell you what I want every person watching this video to do after they finish watching. If you are over 60 with high blood pressure or diabetes or both, I want you to find your most recent blood test result, the one from the last 6 months or the last year. And I want you to look for the word EGFR or estimated GFR or glomerular filtration rate. It is on most standard blood panels, including the basic metabolic panel.
and the comprehensive metabolic panel that are routinely ordered in adults over 60. Find that number, and if it is below 60, or if you can find multiple blood tests from the past 2 to 3 years, and that number has been moving downward, I want you to call your doctor's office tomorrow morning and say, I have been looking at my eGFR on my recent blood test, and I would like to discuss what the trend means and whether I should be referred to a nephrologist, a kidney specialist, for further evaluation. You can also ask whether a urine albumin to creatinine ratio has ever been checked as an additional marker of kidney health. Both of those questions are completely reasonable and clinically appropriate. For any adult over 60 with high blood pressure or diabetes, and a doctor who takes kidney health seriously will welcome them. If you have high blood pressure and diabetes, and you have never had your eGFR specifically discussed with you, despite it appearing on your blood test for years, you deserve to have that conversation now. Not later, not when the number has fallen further, now, while intervention can make the most difference. Let me bring everything together. Chronic kidney disease affects a very significant proportion of adults over 65 in the United States, particularly those with high blood pressure and diabetes. It is almost entirely silent in its early and middle stages, producing no symptoms that the person experiencing it would identify as kidney-related. The only way to detect it is through regular blood testing of eGFR and urine testing for albumin. The eGFR, estimated glomerular filtration rate, is already on most standard blood panels for adults over 60. A single eGFR reading tells you where kidney function is right now. A trend of eGFR readings over 2 to 3 years tells you the story of your kidneys over that time, and whether that story is stable or declining. Margaret's story was declining for 3 years on every blood test she had, without anyone reading the story to her. Now she knows, and knowing was the beginning of slowing and perhaps stabilizing what was happening to the organs that filter her blood 200 liters every single day without rest, without complaint, and without a single symptom that told her they needed help. I am Dr. Daniel Chen. If this video prompted you to look at your blood test and find your eGFR number, please share it with every person over 60 that you know who has high blood pressure or diabetes and who has never been told what the eGFR number on their blood test actually means. It might be the most important video you ever share. Subscribe to this channel for weekly videos made with genuine care for older adults who deserve real information about their own health. And leave me a comment below. Tell me what your most recent eGFR is, if you know it, and whether anyone has ever discussed it with you in the way I have described today. I read every single comment, and I genuinely look forward to hearing from you. Take care of your kidneys. They are doing everything for you every single minute of every single day. They deserve to be noticed before they stop being able to tell you something is wrong.